Welcome to This Week in Cardiology. This week we're covering 10 notable papers spanning antithrombotic and structural decisions in atrial fibrillation and valve surgery, lipid management and residual risk, and a set of practical clinical reviews on shock, hyperkalaemia, and orthostatic intolerance. Let's dive in. We'll start with antithrombotic strategy, where the Journal of the American Heart Association published 2 papers that pull in useful directions. In a Prespecified subgroup analysis of the OPT-BIRISK trial, Zhang and colleagues asked whether the benefit of de-escalating to Clopidogrel monotherapy holds in patients with diabetes. This was a population of patients with acute coronary syndrome at both high bleeding and high ischemic risk, who had already completed 9 to 12 months of dual-antiplatelet therapy after percutaneous coronary intervention, then were randomized to another 9 months of Clopidogrel alone versus Clopidogrel plus aspirin. Just over half of the nearly 8,000 patients had diabetes. In that diabetic subgroup, dropping aspirin cut clinically relevant bleeding by roughly a third, from about 3% down to about 2%, with no signal of increased death, myocardial infarction, stroke, or revascularization. Results were consistent in patients without diabetes, and there was no interaction by diabetes status. The practical message is that diabetes should not be the reason you keep a BIRISK patient on aspirin indefinitely after the first year. Staying with stroke prevention, the same journal reported short-term outcomes of the LAA closure randomized trial from Cardiology and colleagues, which tested prophylactic surgical left atrial appendage closure in 9-1 patients with no prior atrial fibrillation undergoing bioprosthetic surgical aortic valve replacement. At 30 days, the composite of cardiovascular death, stroke, or systemic embolism was about 2% with closure versus about 3% with usual care, a difference that was not statistically significant. What is interesting is the time course. The treatment effect changed direction at around 7 days, with a numerical excess of events early and a signal of benefit later, though neither time window reached significance. Postoperative atrial fibrillation occurred in close to half of patients in both arms, slightly more with closure, again not significant. Importantly, there were no closure-related serious complications and no excess bleeding. So this is a safety and feasibility readout, not proof of efficacy. The longer-term follow-up is what will decide whether prophylactic closure has a role in this population. The third paper in the atrial fibrillation space, also in the Journal of the American Heart Association, is a Taiwanese nationwide cohort from Huang and colleagues, asking whether sodium glucose (COTRANSPORTER2) inhibitors reduce cerebrovascular events after a new diagnosis of atrial fibrillation. Using national insurance data, they propensity matched about 1,900 regular users to 19,000 non-users, mean age 72, mean CHA2DS2-VASC score just under 4. Baseline use of these drugs was not associated with the primary composite of ischemic stroke, hemorrhagic stroke, or transient ischemic attack, nor with mortality, nor with major adverse cardiovascular events. A time-dependent analysis did show roughly a 30% lower mortality with current exposure, but the authors themselves caution that this is likely residual confounding. Their conclusion deserves repeating verbatim in spirit. These agents are not an alternative to guideline-directed oral anticoagulation for stroke prevention in atrial fibrillation. Turning to lipids, 2 papers frame the same problem from opposite ends of the severity spectrum. A systematic review and meta-analysis in the Journal of the American Heart Association from Watanabe and colleagues pooled observational studies of statin users and found substantial residual atherosclerotic risk in real-world practice. A composite rate of major adverse cardiovascular events or death of about 12 per 1,000 person-years overall, roughly 6 per 1,000 in primary prevention, and about 16 per 1,000 in those with established disease. Between study variability was enormous, so treat these as order of magnitude estimates rather than precise rates, but the direction is clear. Statin monotherapy leaves meaningful risk on the table, and the authors read this as persistent treatment gaps rather than an irreducible flow. At the extreme end, the same journal reported a retrospective series of 13 children with homozygous familial hypercholesterolemia, treated with evinacumab, the angiopoietin-like 3 antibody from Rageman and colleagues. Before treatment, not one child was at LDL cholesterol goal. After a median of 2 years, 9 of 13 were. Mean LDL cholesterol fell by about 95 mg per deciliter to just over 110. 11 children were on lipoprotein apheresis, roughly every 8 days at baseline. At follow-up, the interval stretched by about 11 days, a 42% longer gap, and 3 children came off apheresis entirely. On coronary computed tomography angiography, plaque was stable, regressed, or never formed in about 3/4 of the children, with progression in 13 patients is 13 patients, and this is uncontrolled and retrospective. But for families for whom apheresis dominates life, the reduction in treatment burden is a clinically meaningful endpoint in its own right. On the diagnostic side, the Journal of the American Heart Association also published a proof-of-concept validation of an artificial intelligence-driven angiography-based fractional flow reserve from Lee and colleagues, prospectively enrolling 599 vessels across 5 Korean hospitals, with invasive wire-based fractional flow reserve as the reference. The automated computation took about 12 seconds, needed manual correction in roughly 1 vessel in 20, and matched quantitative flow ratio for diagnostic accuracy, with an area under the curve of about 0.95 for detecting a fractional flow reserve of 0.80 or below. Vessels flagged as abnormal by the algorithm had a higher rate of target vessel failure at 2 years, about 4.5% versus under 1%, and prognostic discrimination was comparable to quantitative flow ratio. This is validation against another angiography-derived index, rather than an outcome trial of a wire-free strategy, so it is a step toward, not a replacement for, physiology-guided decision-making. 3 reviews round out the week, and each is worth downloading. Circulation published a clinical primer from Bohula and Morrow on vasoactive agent selection in cardiogenic shock, which offers a sequenced framework rather than a drug ranking. Protect the mean arterial pressure emergently, then define the hemodynamic phenotype and chase reversible contributors in parallel, then set goals beyond blood pressure alone, and then titrate iteratively against perfusion. Given how thin the comparative effectiveness evidence remains here, a disciplined phenotype-first approach is probably the most transferable thing in the paper. The BMJ published a state-of-the-art review on acute hyperkalaemia from Rech and colleagues, relevant to every clinician titrating renin, angiotensin-aldosterone blockade in heart failure and chronic kidney disease, and emphasizing how variable definitions and thresholds remain, even as newer potassium binders change chronic management. And in JAMA, Chung and Raj reviewed postural orthostatic tachycardia syndrome, affecting perhaps 1 in 1,000 to 1 in 100 people in the United States, about 90% of them female, with peak onset in the teens and 20s, and in 30 to 40% of cases, onset within 3 months of an infection. In a survey of nearly 5,000 patients, around 70% reported substantial functional impairment, with a median diagnostic delay of 2 years. The diagnostic criteria are worth committing to memory: a sustained heart rate rise of at least 30 beats per minute within 10 minutes of standing, 40 in adolescents, without orthostatic hypotension, and first-line therapy remains volume and sodium loading, compression garments, and structured supervised aerobic training before drugs. One more preventive signal from the Journal of the American Heart Association. Demmer and colleagues studied nearly 81,000 adults in the Rochester Epidemiology Project and found that hospitalization for infection was associated with nearly double the risk of incident heart failure over a median 6 years of follow-up. Adding infection history to the prevent heart failure equations barely moved overall discrimination, but the risk score underestimated 10-year risk by up to 9% in people who had been hospitalized with infection. Practically, a serious infection admission is a reasonable trigger for closer cardiovascular surveillance, even though it does not belong in a population risk calculator. If you only have time for one paper this week, make it the OPT-BIRISK diabetes subgroup analysis in the Journal of the American Heart Association. It answers a question that comes up in clinic constantly and supports de-escalating to Clopidogrel monotherapy in high-risk patients with diabetes, rather than defaulting to indefinite dual therapy. Here are the key takeaways from this week in cardiology. First, in patients at both high bleeding and high ischemic risk after percutaneous coronary intervention, diabetes is not a reason to withhold de-escalation to Clopidogrel monotherapy after the first year. Second, sodium glucose, COTRANSPORTER2 inhibitors do not substitute for anticoagulation in atrial fibrillation, and prophylactic surgical appendage closure during bioprosthetic aortic valve replacement is safe, but has not yet shown short-term efficacy. Third, residual risk in statin users in real practice is substantial, which should push you toward combination lipid lowering rather than declaring victory on a statin alone. And at the extreme end, evinacumab is meaningfully reducing apheresis burden in children with homozygous familial hypercholesterolemia. Fourth, A hospitalization for severe infection nearly doubles subsequent heart failure risk and is a reasonable prompt for closer follow-up. And fifth, in postural orthostatic tachycardia syndrome, diagnostic delay averages 2 years, so know the criteria and start with volume, compression, and graded exercise. That's your roundup for this week in cardiology. The full transcript and references are available on the episode page in your Audio Scholar library. This is an AI-curated summary. For clinical decisions, always consult primary sources and current guidelines. See you next week. If this weekly briefing is useful, follow the show in your podcast app so new episodes arrive automatically. And think of one colleague in any specialty who never has time to keep up with the literature. Tell them about Audio Scholar, a free 10-minute weekly for every specialty, to listen to in any podcast app or to read at audioscholar.cc. This is an automated summary generated by artificial intelligence, which can make mistakes. Always review the original source materials.